All right, Ms. Aker.
Sir, could you please state and spell your full name for the record?
Sure. Paul Shane Uribe, Paulshaneuribe.
And what is your occupation?
My occupation is a forensic pathologist.
And for our benefit, what is forensic pathology?
Forensic pathology is a specialty of medicine that specializes in unnatural, unexpected, or violent death.
Do you have any military experience?
Yes.
What sort of professional training do you have?
Professional training includes medical school from the Uniformed Services University of the Health Sciences, which is the military medical school in Bethesda, Maryland, a transitional internship, a residency in anatomic and clinical pathology, and a fellowship in forensic pathology.
And where are you currently employed?
I currently work as the Deputy Chief Medical Examiner at the Fort Bend County Medical Examiner's Office in Rosenberg, Texas, southwest of Houston.
Prior to your current employment, what is your past work experience?
Past work experience includes 23 years and change at U.S. Army. In the Army, I worked as a general pathologist. I worked as a medical examiner, a forensic pathologist with the Armed Forces Medical Examiner System. I've also worked part-time in several jurisdictions, including Clark County, Nevada, which represents Las Vegas and Southern Nevada, the state of Mississippi, New Jersey, Baltimore, spent some time in South Carolina. So I've had a couple of part-time jobs in addition to my full-time employment.
Do you have any peer-reviewed publications?
Yes.
Have you presented at national and international forensic conferences?
Yes.
And do you have any board certifications?
Yes.
What about active state medical licenses? How many of those do you carry?
I currently have 9 state medical licenses, all in good standing.
Are you a member of any professional organizations?
Yes.
And what might those be?
The National Association of Medical Examiners and American Academy of Forensic Sciences. I'm on multiple committees and working groups for both of those organizations. I'm also a member of the International Association of Coroners and Medical Examiners, the College of American Pathologists, which is the largest group of pathologists in the world, and the American Society of Clinical Pathology.
In your career, about how many autopsies have you personally performed?
I've personally performed over 2,500 autopsies.
And in your work as a forensic pathologist, have you ever been involved in any high-profile cases?
Yes.
Just briefly, an overview, what kind of cases were those?
There were, let's see, my first...
We object to that question. It's irrelevant to these proceedings.
Your Honor, I would argue that if you were allowed to answer, they would be relevant cases.
Overruled. I'll permit the witness to answer. Go ahead, please.
My first high-profile case in the military was a group of Christian missionaries who were kidnapped by Somali pirates. This was back in 2010, 2011. I wrote the federal opinion for the George Floyd case, and I did a series of suspected insulin homicides in a VA hospital in Clarksburg, West Virginia.
Your Honor, subject to cross-examination by the defense, I would ask that this witness be treated as an expert in the field of forensic pathology pursuant to Rule 702.
All right, Mr. Selden, do you wish to engage in voir dire pertaining to this witness's credentials?
No, Your Honor. We accept him as an expert.
All right, the court declares this witness to be an expert in the field of forensic pathology.
Thank you, Your Honor. Dr. Uribe, did you prepare a report in this case?
Yes.
And I am now holding what I would ask to be marked as, I believe, states 21.
21, Your Honor.
Thank you.
Dr. Uribe, could you just briefly look over that and tell me if that is the report that you wrote in this case?
Yes, it is.
Does it appear to have been altered in any way from the way that you submitted it?
No.
Did you review certain records when preparing your report in this case?
Yes.
Could you briefly tell us which records you reviewed?
The records I reviewed were medical records from the Charleston Area Medical Center, Raleigh General Hospital, some hospice records, the initial autopsy report and autopsy photographs, and investigative documents, including interviews, investigative statements from police and other investigative officers.
Dr. Uribe, did you chart Mr. Cochran's glucose and potassium levels from his medical records?
Yes.
And does this accurately reflect the chart that you produced?
Yes.
What about those levels were significant to you?
There was significant, I wouldn't say significant, I would say profound hypoglycemia. Hypoglycemia is low blood glucose. His admission glucose level was 21, which is incredibly unusual. It's also associated with a low potassium as well. Later on in the hospitalization, once he was treated for the hypoglycemia, the blood sugar went up and then it went back down again. This is a pattern that I refer to as refractory hypoglycemia, which is where someone comes in hypoglycemic, you treat them with sugars, their blood sugar goes back up, but then something is dragging the sugar back down. And that is a, to me, that is a significant pattern.
And why is that pattern significant to you?
Because there are only a few things that can do that. One of the big things is insulin administration, because insulin or certain other drugs like oral hypoglycemic agents, which are oral drugs that you take to control diabetes, that drug effect from either insulin or these other agents serve to continue to drag the sugar levels down despite treatment. So you give someone who's hypoglycemic sugar, you expect it to bounce back up and stay that way, but there's some sort of force that's pulling the sugar back down again, and that to me that's a significant red flag.
And given that you classify it as a red flag, had you seen this in a clinical setting, what sort of testing would you have performed?
The testing to be performed, when you suspect exogenous insulin administration, meaning insulin being given that's unprescribed, there's a very, very small window where you can do adequate testing. The classic teaching is you draw for laboratory testing, you draw an insulin level and a C-peptide. Now, if I may explain to the jury what these two things are. So the body makes a protein called proinsulin. And when insulin is about to be released by the pancreas, proinsulin is basically, essentially cut in half. And half of it is, what's regarded as insulin. The other half is something called C-peptide. So when you test for insulin and C-peptide levels, you expect them to be, essentially in a 1-to-1 ratio, because you have one molecule, you break it in half, you have, two representative pieces. When you administer insulin to someone, you have a lot of insulin, but no C-peptide, because that C-peptide wasn't, cleaved off and wasn't relieved by the body, or wasn't released by the body. So when you suspect...
Your Honor, at this point, we have to object to this testimony. This witness is an expert in forensic pathology. Now he's testifying as to chemistry and other matters that go out of his range of expertise. This testimony is about chemical effects, and Dr. Krieger was the expert specialized in this area, not this witness. He's a forensic pathologist.
I think he's laying the groundwork, and I think it relates to his field. I'll overrule the objection. Dr. Uribe, you can continue.
So When you have exogenous administration of insulin, meaning administration of insulin from an outside source, if you suspect that, when your patient is hypoglycemic in front of you, so when they're, profoundly hypoglycemic, and you suspect that, you need to draw an insulin and C-peptide level then. If you draw it after you administer treatment, then the body starts releasing natural insulin, so you're going to get that C-peptide again. And when the laboratory testing that you would expect in insulin administration is a high insulin level with no C-peptide. But once again, there's a very, very short window of testing where clinically you can order this.
Any of that testing have been performed after Mr. Cochran passed away?
No, because there's no postmortem utility in insulin and C-peptide levels postmortem.
Did you review imaging studies in this case?
Yes.
Were any of those indicative of head trauma?
No.
Now, you performed an autopsy on Mr. Cochran's remains, correct?
Yes.
About how long after Mr. Cochran passed away did your autopsy take place?
It was over 2 years.
Can you explain to us why there was such a long window between his death and your autopsy?
I was asked to do a second autopsy by the Raleigh district attorney at the time, Benjamin Hatfield, because of the suspicious circumstances in this case.
What was the condition of the body upon exhumation at the time of your examination?
There was marked decomposition. And what I mean by marked decomposition is I was told that the body was embalmed. If they were embalmed, they weren't embalmed very well at all. The body basically consisted of a skeleton with some degree of soft tissue that had turned into what we call adipocere, which is like where the fatty tissues of the body turn into almost like a hard chalky soap. It's a natural natural type of decomposition. So there was some adipocered soft tissue, and the body was largely skeletonized.
Is there a typical protocol that you follow when you conduct an autopsy?
Yes.
Can you just very briefly, very high level, explain for us what that looks like?
Sure. So you never want to do an autopsy in a vacuum. So the first part, and sometimes the most important part, is review of the circumstances of death. You never want to do an autopsy in a vacuum and just here's a body, figure out why they died, because you need to know as much as you can about the circumstances of why they died. So the investigation, medical records, everything preceding when the person died, and then once you're doing the autopsy, it's broken up into several parts. The first part is the external examination, where you look at the body. You basically just describe what you see. Height, weight, eye color, hair color, evidence of trauma, evidence of natural disease, evidence of injury, things like that. Once you finish the external examination, you can open the body and do an internal examination. The internal examination, once again, looks for evidence of trauma, looks for evidence of natural disease. You take out the internal organs and dissect them, looking for evidence of natural disease, trauma, things like that. You can collect tissues or body fluids for additional testing or microscopic analysis. Once you've finished the external or internal examination, then you can, send for ancillary studies, which include microscopic analysis of tissue, analysis of blood or other tissues for toxicology to see what drugs were in, what drugs or medications were in the body at the time of death. And then you correlate all of these findings together, the scene investigation, the autopsy findings, the ancillary studies, and we use that to reach a cause and manner of death.
And what did you determine were Michael Cochran's cause and manner of death?
Michael Cochran's cause and manner of death there's a lot of circumstantial evidence in this case that does not correlate with the autopsy findings or medical record. And whenever we have that, I call it a discordance, or things that don't add up or make sense. Those are sort of the red flags that we look at. With the entirety of the circumstances, including the initial autopsy findings, the second autopsy findings, which there weren't much, the history of profound hypoglycemia that's very much unexplained. I came to the conclusion that the cause of death was exogenous insulin administration, and there's no explanation for why a non-diabetic, otherwise relatively healthy male would have such profound hypoglycemia, and also refractory hypoglycemia as well. And there's no other viable explanation for it. The only reasonable conclusion that I could make is that he was given insulin.
And so specifically, what is his manner of death?
Manner of death would be homicide, because there's no evidence that he administered insulin himself. People don't accidentally administer insulin to themselves or given.
Your Honor, we object at this time. The statement that it is a homicide, that's for this court to decide. It is the conclusion that this witness cannot come to.
Your Honor, that is a manner of death which is determined by all medical examiners.
The objection's overruled.
Dr. Uribe, what other possible causes did you rule out when you reached that conclusion?
So when doing an autopsy, you look at the totality of the case, and sometimes you can break it down into different pieces, but you have to look at everything in its totality. The circumstances in this case, was there evidence of trauma? There was a questionable fall as the initiating event, but there was no evidence of trauma in the medical records. There was a questionable evidence a questionable seizure. Once again, I'm not sure a history of seizure disorder has been substantiated, so that sort of remains a question. There are other causes such as heart disease. Could heart disease cause someone to go unconscious? Sure, I see it all the time. People with hypertension and heart disease, they can have a cardiac arrhythmia as well. But these cardiac arrhythmias aren't due to hypertension and a bad heart. They're not associated with hypoglycemia at all. There was a question of steroid use or clomiphene and clomiphene, which is enclomiphene is an androgen agonist, and a lot of men use, in women it's used for fertility treatments to hyperovulate, because what this drug does is it causes the body to produce excess sex hormone. When used in men, it's used to sort of reboot natural testosterone promotion. But enclomiphene by itself is not associated with seizures, is not associated with cardiac arrhythmia. So that didn't make sense either. There are other causes of hypoglycemia. There could be a pancreatic tumor that secretes insulin periodically. Those are incredibly rare. There's a number of other medical conditions that can, but there's no evidence substantiating any of those other causes. And why would they suddenly present during this time when the medical history and circumstances are suspicious? So there are very, very few causes that would cause an otherwise healthy 38-year-old male to have a blood glucose of 21 that's confirmed by the lab. And especially with the associated hypokalemia, which is the low potassium as well. When you have profound hypoglycemia and hypokalemia, so low blood sugar and low potassium, with no other reasonable or viable explanation, I came to the conclusion that, you know, this is likely due to insulin that was administered at some point.
And has anything come to your attention since generating your report that would change any of your conclusions?
No.
Thank you. I have no further questions for this witness.
Cross-examination, Mr. Selden.
Yes, Your Honor. Good afternoon, Dr. Uribe. I am Stanley Selden. I am co-counsel for the defendant, Natalie Cochran.
Good morning, sir.
Good morning. And again, how did you learn of this case?
I learned of this case from the previous Raleigh District Attorney, Benjamin Hatfield.
Okay. And were you hired by the Raleigh County Prosecutor's Office to testify in this case?
I was hired by the Raleigh County Prosecutor's Office to look at this case, at the time possibly perform a second autopsy, which we ended up doing, and then subsequently for my testimony in this case, yes.
So the state and the Raleigh County Prosecuting Attorney's Office is paying you for your services, isn't that correct?
They're compensating me for my time, yes.
And I believe you said that you have done over 2,500 autopsies, and have you testified in an equal number of cases?
I've performed over 2,500 autopsies. I've testified approximately 40 times.
Okay. And of those 40 times, have you always testified for the prosecution in court?
No.
Sorry?
No.
No. About how many of those cases have you testified for the prosecution?
Approximately, it's about an 80-20% split. It's heavily weighted towards the prosecution because I'm often the medical examiner who performed the autopsy. So in a case of someone who got shot, I'm the doctor who performed the autopsy. I'm naturally called by the prosecution. But I do take defense cases as well.
Now, you said you weren't really sure. It was a number of years when you conducted your autopsy. Would it surprise you to learn that you conducted your autopsy almost 4 years after the date of death of Michael Cochran?
I may have been confused about my dates, but that could be true. I would have to check my report to verify the dates.
I submit that Michael Cochran died approximately February 11th of 2019, and your report is authored, it has a date of April 5th of 2024, so that's almost 5 years, isn't that correct?
Yes, and the second autopsy was performed in July of 2023.
Okay. The first autopsy, conducted by Dr. Kubitschek, was conducted only 7 months after Michael Cochran's death. Were you aware of that?
Yes.
And the first autopsy was done, and the results were because the body was much less decomposed after 7 months than after 5 years, correct?
Then after...
You conducted your autopsy almost 4 years after the original autopsy. The state of the body would have been vastly more decomposed. Isn't that correct?
Yes, the body was vastly more decomposed, and a lot of that is because I don't think he was properly embalmed. If he was embalmed, the body obviously would have been in better shape.
I did not ask the reason. I just asked about the time period. Thank you. You've answered the question. Did the advanced decomposition limit your ability to make certain diagnoses?
Yes.
Was there any finding during your autopsy that detected any insulin in Michael Cochran's body or any C peptides?
No.
And this could not be determined because of the advanced composition of the body. Isn't that correct?
That's correct, and there's also no,
Thank you. You answered the question. Now, because you did not detect insulin or C-peptide in the body because of the advanced decomposition, how did you conclude that it was insulin administration related to death?
it was a clinical correlation from review of the medical records.
Can you say with absolute medical certainty that exogenous insulin administration was the cause of Michael Cochran's hypoglycemia and death?
I can say with,
Absolute certainty, 100%.
I don't use the term absolute for anything.
Despite all of your assertions, you cannot accurately conclude that exogenous insulin administration is the cause of death, can you?
I don't believe that statement is true.
I'm sorry, I didn't hear your answer.
I don't believe that statement is true. I think you can, based on clinical correlation in the absence of any other viable explanation for profound or refractory hypoglycemia, hypokalemia, in the absence of any other causative finding for it.
Was there any testing in the medical records from any of the hospitals that showed insulin and C-peptide levels?
No.
Sorry?
No.
Okay. And there was no testing like this because there was no suspicion whatsoever by his doctors that he had been...
That calls for speculation. He can't testify as to the suspicions of his doctors.
Sustained.
Despite all of the testing in the hospitals that Michael Cochran underwent, there were no tests done for insulin in his body. Isn't that correct?
Correct.
Do you know what the medical term refractory hypoglycemia means?
Yes.
And isn't the definition of refractory hypoglycemia that it is a prolonged period of low blood sugar that doesn't respond to standard treatments?
That's not the definition.
What do you think the definition is?
The definition of refractory hypoglycemia is hypoglycemia that persists despite treatment for the hypoglycemia.
So, do you know that to correct low blood sugar, like the ones demonstrated in Michael, that to control that, it requires high doses of glucose or continuous monitoring?
Yes.
So by your testimony, did Michael Cochran have refractory hypoglycemia?
Yes.
Isn't the correct answer to that question no, because his blood sugar responded to therapy? He was given D50 glucose and his blood sugar levels went down.
Your Honor, I'm going to object to that question. The witness has already answered the question, and Mr. Selden has simply rephrased his answer.
I think it's a fair question. I'll allow it. The objection's overruled. Answer if you can, please, Doctor.
Yeah, and I want to clarify. The question is, his blood sugar responded to therapy. He was given D50 glucose And his blood sugar levels went up, not down.
Yes, his blood sugars did respond to glucose therapy, but then they also subsequently went down after they initially responded. That is the definition of refractory hypoglycemia.
Your Honor, at this time I would like to have defendant's exhibit number 10.
All right.
Dr. Uribe, this is a chart very similar to the one you use, which shows the date and time of the monitoring of Michael Cochran's blood glucose levels. And it has a column, number 3, that suggests the hours since allegedly Michael Cochran was injected with insulin, which appears from testimony to be around 12 p.m. on February 6, 2019. And the last or fourth column has a listing of whether insulin, Lispro Humalog insulin, was active in his body. Okay? Do you see that chart and those columns?
Yes, I see the chart.
Now, on February 6th of 2019, at 8:20 p.m., which is 20 hours by Mexico time, his blood glucose level was 21, which was approximately 8 hours and 20 minutes after insulin was allegedly injected in him. Do you see that column?
Yes, I see the column.
Was Humalog insulin active in his body? Was it still working in his body?
I would say yes, but I do object to some of the columns of this chart.
Your objection is noted, but we're going to go through it, and I'm going to ask you questions about it. How long do you think human Lispro insulin is active in the body? How long does it work?
It usually works within, or it usually works 4 to 6 hours, but there,
I'm sorry, but 4 to 6 hours. Right?
4 to 6 hours, but there's also a dose dependent. If you get a large dose, then the effects can last longer. It's a very difficult thing to study because we can't inject otherwise healthy people with superhuman levels of insulin and see how long it takes for the insulin effects to wear off. But with the average dose of Lispro insulin, the average expectancy of it functioning is 4 to 6 hours. But there is a dose-related effect of that as well.
So if Michael Cochran was given an injection of a, as you term, fairly normal dose, the Humalog insulin would only be expected to work 4 to 6 hours. Isn't that correct?
Yes, but it raises...
Those are questions. Now, February 7th of 2019, he's being closely monitored. We don't have a blood glucose level there. It's now 12 and a half hours, approximately, since the alleged injection. 12 and a half hours, under any circumstances, a normal dose, or however you want to term it, of insulin, it's no longer active in the body. Isn't that correct?
At 12 hours, generally no, but there's also the dose-dependent feature, which I discussed
You already made
earlier.
that statement. Generally, no. Human insulin isn't active in the body after 12 and a half hours, correct?
Generally, no.
The next two entries, well, the next entry is also on February 7th, now 12 hours and 5 more minutes since the last meeting. February 7th, 2019, at 12:30, I believe it's 12:33 a.m. Now, his glucose levels are going up. He's responding to treatment because sometime around that time, he was given a dose of D50 glucose. D50 glucose is used to raise blood glucose levels. Is it that correct?
Yes.
So he's responding to treatment at this time. Would that be a fair statement?
Slightly, but he's still significantly hypoglycemic.
Well, and that depends on what your definition of hypoglycemia is. If the threshold is 70 milligrams per deciliter in a person without diabetes, that could be considered hypoglycemia.
Yes.
Thank you. Next two columns, his blood glucose level is going up. It's now 80 and then 187. And he's responding to the treatment. His levels are going up. Wouldn't that be correct?
Yes.
Now, suddenly, approximately 3 hours later, his blood glucose levels are going down. They've gone from 187 all the way down to 44. Isn't that correct?
Yes.
And you really can't state why, correct? You talk about refractory hypoglycemia, other causes, etc. It's really unknown why his blood glucose level goes down to 44. Would that be correct?
Correct.
At 6:22 a.m., approximately an hour later, his glucose goes back up to 95. We don't know why. Correct?
Correct.
Then at 10:33 a.m., about 4 hours later, back down to 60. We can't positively say why that happened. Correct?
Correct.
And from the other time marks, from February 7th through February 8th, his blood glucose levels have now gone way up, and by any definition, they would be within normal limits. Isn't that correct?
They're above normal limits.
But they're no longer low, and they're no longer indicative of hypoglycemia at that time. Correct?
Correct.
So in summary of that, from February 7th, 2019, 11:53 a.m., when the blood glucose levels are at 154, and afterwards, you cannot say Humalog insulin was active in Michael Cochran's body at those times. Isn't that correct?
Correct. That would make sense.
For clarification, what are the causes of hypoglycemia that you considered?
Could you repeat the question? Because I can't tell if you said hypo or hyperglycemia.
Hypo, H-Y-P-O.
Okay, hypoglycemia can be caused by a number of different things, including, pancreatic tumors, which can spontaneously secrete insulin. These are fairly rare. They were not identified.
Excuse me, Dr. Uribe, I don't want an extended explanation, just what the causes were.
Causes include adrenal insufficiency, drug or medication effect, pancreatic tumors, sepsis, multisystem organ failure.
Okay,
Those are the big ones.
all right. You state in your report that insulinoma, which is insulin-producing tumors in the pancreas that can cause hypoglycemia, that was excluded by the first autopsy, but this isn't really true, is it? The first autopsy didn't exclude that. Isn't that right?
They did not identify a pancreatic tumor.
Okay. Isn't it true that when the body decomposes, the organs of which pancreas is one of the first organs to decompose?
Yes.
Okay. So in the first autopsy and your autopsy, the second one, because the pancreas was essentially decomposed, you can't determine whether there are any tumors producing insulin. Wouldn't that be a fair statement?
I can go by what Dr. Kubitschek said in his report, and that no pancreatic tumor was identified.
Okay. It's reported that Michael Cochran used medications he ordered from abroad. He used various substances, and you can't exclude those substances or medications as having caused his hypoglycemia because you don't know what they were. Wouldn't that be a correct statement?
The medication.
They're not listed anywhere, so you can't include or exclude them, correct?
The medications that I am aware that he was taking are not associated with hypoglycemia.
I'm talking about ones that weren't included. No accurate reportings of what those were. You can't exclude them because you don't know what they were, right?
Sure.
Okay. And any substances, medications, etc., can't be excluded because they could have been eliminated from his body after death and decomposition. Isn't that correct?
Can you repeat the question?
Yeah. Any of these substances, medications, etc., cannot be excluded because they could have been eliminated from his body after death and decomposition. Isn't that correct? The substances are gone.
Some substances would be affected by decomposition. Some medications and drugs would be able to be detected despite decomposition, even in an autopsy 7 months after death.
Okay. You said, now, let me rephrase. You can't definitively say that insulin was present in Michael Cochran's body after his death and decomposition. There was no insulin in his body, correct?
Insulin rapidly degenerates and decomposes. That's one of the reasons why postmortem insulin testing and postmortem C-peptide testing is, you can't do it. There's no utility for it.
Okay, so you can't tell if insulin was in his body for all the reasons you talked about, right?
Correct.
Okay. And after death, you say you can't do any kind of insulin testing, right? Post-mortem insulin testing can't be done.
There are some ways you can detect insulin post-mortem.
Okay. Did you do any of those tests that showed insulin in his body?
No.
So because of that, because there wasn't any tests or insulin present in Michael's body after death, you cannot say with absolute medical certainty that insulin was involved in Michael Cochran's hypoglycemia or death, can you?
First, I wouldn't use the term absolute, and there is no other viable explanation for profound hypoglycemia in a non-diabetic, otherwise, relatively healthy male. There are no natural conditions that bring someone's blood glucose to a lab-confirmed level of
All right,
21.
you've made that statement. Let me clarify with some other questions. What if you were told that Michael Cochran injected himself numerous times with insulin prior to his death? Would that change your conclusions? And let me clarify a little more.
It's possible, but why would a non-diabetic person inject themselves with insulin?
Well, that's a good question. If they were a bodybuilder and they were using insulin to assist them in their bodybuilding, enhancing their body for various reasons, that could be a reason for self-injection of insulin, couldn't it?
To my knowledge, bodybuilders don't use insulin.
Really? So you don't know that Mr. Olympia died from overdosing himself with insulin. That's history. You weren't aware of that?
What is the relevance of how Mr. Olympia died and the fact that he was using insulin? We don't even know that he was using it as a bodybuilding technique.
Because he just said he doesn't know why anyone would inject themselves with insulin.
I'll overrule the objection. Please continue.
Thank you. Were you not aware Mr. Olympia, a bodybuilder, died from self-injected insulin?
No.
Okay. Were you not aware that in the Journal of Emergency Medicine, Volume 56, Issue 3, March of 2019, there is an article by Matthew Heidet, Heidet, MD, that is devoted to severe hypoglycemia due to cryptic insulin use in a bodybuilder. Were you never aware of that article?
No, I'm not aware of a solitary case study that was written 5 years ago at this point.
All right. Well, if you had reviewed that article, it doesn't talk about one specific case. It references many cases. Okay? So, it's possible, maybe even probable, that Michael Cochran, a bodybuilder, used insulin. That would be a reason. Correct?
I'm not aware of it. I would be happy to review the article if you were to provide it.
All right. Michael Cochran is documented in many medical records that he had an enlarged heart, correct? And specifically, I'll reference you to his discharge summary, which says he has an enlarged heart. Okay? That was
Okay.
one of his diagnoses.
Okay.
All right. Isn't it true that chronic long-term substance abuse can cause an enlarged heart?
Yes.
Are you aware that when a person is in a coma or has been unconscious for a long period of time and they're admitted into the hospital, that their naked body is thoroughly examined by hospital staff to determine such things as bruising, external signs of trauma, etc.? You aware of that?
Generally, yes.
Okay. And nowhere in the hospital medical records is it cataloged that there were any injection sites or signs of injection in Michael Cochran's body. Isn't that correct?
That's correct.
Isn't it more likely that Michael's chronic substance abuse, his seizures and seizure history, his swollen brain or edema, his abnormal liver enzymes and liver problems, his possible abuse of testosterone, his enlarged heart, and all of this combination of things, which you call a constellation, that they caught up with Michael and resulted in his death, not because of anything Natalie Cochran did?
None of the things you listed would present as severely profound hypoglycemia on admission.
Because of all of these things, Michael was not a healthy 38-year-old male. Isn't that correct?
It depends on what you consider your definition of healthy is.
Okay. Dr. Kubitschek's autopsy examination 7 months after Michael's death showed no physical evidence of insulin or insulin injections in Michael's body. Isn't that correct?
Yes, but I don't believe he was looking.
You answered my question. And you conducted an autopsy approximately 4 years after Michael's death with still no objective physical evidence of insulin in Michael's body. Isn't that correct?
Correct.
So the only reasonable conclusion is that you cannot determine the cause and manner of Michael Cochran's death, and as Dr. Kubitschek stated, you cannot determine the cause of death, it's undetermined, and you cannot determine the manner of death, it's undetermined. Isn't that correct?
Cause and manner of death are both opinions. I believe the circumstantial evidence in this case, I've already stated my opinion on that.
All right. I don't believe I have any more questions at this time.
All
Just
right.
a moment.
Redirect Ms. Akert.
Your Honor, I need to confer with counsel.
Okay.
When Humalog insulin, or any other type of insulin for that matter, but specifically Humalog Lispro insulin, once it's injected into the body, its effects or activity in the body, its effects in the body are not instantaneous. It takes approximately 15 minutes to begin working. Isn't that correct?
It takes a period of time, 5 to 15 minutes generally.
Okay. So if Michael Cochran were injected with Humalog insulin, he wouldn't just drop to the ground unconscious. It would take time for the effects to begin. Wasn't that true?
If you're talking about collapsing right after injection, that would not happen.
Okay. Thank you. No more questions.
All right, now, Ms. Akert.
Dr. Uribe, when you reviewed the medical records in this case, did you also review the toxicology report from the hospital? In fact, sorry, the urine drug screen.
Yes.
Was there anything remarkable about that?
Their urine admission drug screen was positive for benzodiazepines.
Did you review Dr. Krieger's report in this matter?
I believe I did, but I did after I had written my consultation, because I didn't want her opinion to bias mine.
And as you stand here today, what is your opinion on that report?
On Dr. Krieger's report?
Yes, sir.
I think Dr. Krieger is an eminently qualified endocrinologist who has the clinical background of treating diabetic patients, which I don't have. I mean, I don't really treat my patients.
Your Honor, his opinion of Dr. Krieger really doesn't figure into his testimony.
Your Honor, we've repeatedly asked about the opinion of Dr. Kubitschek. I don't see why the opinion of Dr. Krieger is any different.
Overruled.
You can continue if you have anything else to add, Dr.
Oh,
Uribe.
no, I have nothing else to add.
Thank you. Did the fact that you were hired by the state to do a report in this matter affect your testimony in any way?
No.
In addition to the advanced decomposition of Mr. Cochran's body, why were you unable to perform insulin and C-peptide studies during your autopsy?
Because there's no utility in testing for insulin and C-peptide post-mortem.
Do you have any way of knowing how many doses of insulin Mr. Cochran would have received before his death?
No.
In your opinion, what was the mechanism that ultimately caused Michael Cochran to die?
I believe the clinical correlation and medical record review demonstrates with the profound hypoglycemia and hypokalemia, which I previously described, that there was an exogenous administration of insulin. It does not appear to me to be self-inflicted nor accidental in nature.
And based on your review of the medical records that you received, who was Mr. Cochran's alleged supplement and insulin use reported by?
Could you repeat the question?
Sure. Based on your review of the medical records that you went over in preparing the report, who provided the information that Mr. Cochran was allegedly using supplements or insulin?
There was some reports that he was using enclomiphene, and this is all information I received from the Raleigh District Attorney. And I was not aware of him administering insulin to himself, or that was a possibility.
Okay. Mr. Cochran was reportedly unconscious the afternoon of February 6, 2019. Is that correct?
Yes, that's how it was. That's how the history was reported.
And was it also reported that his wife checked his blood sugar and it was in the 140s at that time?
I've also received that history, yes.
So do you see any way possible that he could have injected himself with insulin?
Objecting to that, cause for speculation of this witness, he has no knowledge.
Overruled. You can answer, Doctor.
Could you repeat the question one more time, please?
Sure. Based on those facts, the fact that he was unconscious the entire afternoon and the fact that his blood sugar was reported at 145, do you see any way that he could have injected himself with insulin during that time?
I'm going to object again. It's not time specific. She's not asking any time frame for injection.
Okay, that's fair. Put it in a time frame, please, Ms. Eckert.
I'll rephrase, Your Honor. Are you aware of any way that an unconscious person could inject themselves with insulin?
No, and I don't know what the timeline of insulin administration would be, or if it was a single or multiple doses of insulin. I can't exclude that either.
Is there any other information that you believe the jury needs to consider in order to decide this case?
I don't believe so.
Thank you. I have no further questions, Your Honor.
Recross Mr. Selden.
Yes, Your Honor. Thank you. You were asked by Ms. Eckert that you were aware that benzodiazepines showed up in Michael Cochran's urine. Is that correct?
Yes.
But there's no reporting or reason or any accounting of how those benzodiazepines showed up in his urine. Isn't that correct?
Correct.
Now, you mentioned sepsis as a possible cause of hypoglycemia, correct?
Yes.
And sepsis is an infection in the body. Wouldn't that be a fair statement?
Yes.
Now, an infection in the body is usually fought by the body's white blood cells, right? That's essentially what they do. They fight infection or foreign substances in the body.
Yes, the white blood cells are part of the human immune system.
Okay? Are you aware that Michael's white blood cell count was highly elevated when he was admitted to the hospital and in subsequent testing?
Yes.
So, wouldn't that indicate that infection or sepsis in Michael Cochran's body might be another reason for his hypoglycemia?
That is a consideration.
Fair enough. And there were some questions by Ms. Aker, something about how could an unconscious person inject themselves, etc. You don't know the absolute reason for Michael Cochran's collapse and unconsciousness, which was initially reported. Isn't that correct?
Correct.
No further questions.
Anything further, Ms. Aker?
Very little, Your Honor.
Go ahead.
Dr. Uribe, are you aware of other causes of elevated white blood cell counts outside of infection or sepsis?
Yes.
Could you just briefly elaborate?
There are lots of causes for elevated white counts. Elevated white counts could be due to a stress reaction. It could be due to sepsis. It could be due to any type of infection. It could be due to any type of inflammation in the body. There is a very, very broad differential diagnosis for an elevated white count.
And when you reviewed Mr. Cochran's medical records, did you also review his allergies?
Yes,
Did he have an allergy to a benzodiazepine?
it was listed in his medical record.
No further questions, Your Honor.
Go ahead.
Despite the number of other reasons for sepsis and infection, elevated white blood cell count can be an indication of an infection and possible sepsis, correct?
Correct.
No further questions.
Anything, Ms. Aker?
No, Your Honor.
May this witness be excused.
Yes, Your Honor.
Thank you very much, Doctor. You may be excused.
All right, thank you, Your Honor.
Thank you. All right, let's take our mid-morning break at this time. Members of the jury, please do not discuss the case.